Very good evening, everyone. Uh, I have a little sore voice and bad cough, so please excuse me for that. Today we'll be discussing laser-related events. So we will be discussing two case. I will be presenting two case and then with the discussion. So, a 32-year-old gentleman, he came to Shankar Netralaya for LASIK opinion. He had he has history of using glasses since childhood, and he complains of occasional floaters since childhood. There was no complaint of flashes. There is no other ocular or medical history, no significant family history. His best corrected visual acuity in the right eye is 6 by 9 with minus 17.5 diopter sphere with near vision N6, and in left eye 6/9 with minus 14 diopter N6, 14 diopter sphere with near vision N6. Uh, his anterior segment findings were within normal limits. He had a posterior subcapsular cataract in the right eye and early lenticular changes in the left eye. His IOP was normal. Uh, Coming to fundus examination, here we can see it looks like a myopic fundus with lattices present. Here we can see a spontaneously attached retina in the left eye. Again, there was lattice almost in the three quadrants and a myopic fundus. He looking at his fundus, he was advised barrage laser in the both the eyes. The pros and cons of the laser was clearly explained to him, and barrage laser was done in both the eyes in two sittings. Topical steroids were started. 6 days later, he presented to the emergency with sudden drop of vision in left eye with field defect. His best corrected visual acuity in the right eye was 6/9, and in the left eye it has dropped to counting finger at 1 meter. So, post barrage laser 1 week, we could see this is the fundus photo of the left eye. We could see the media is still clear. Uh, we could see the laser marks, fresh laser marks done 1 week back. Here we could see some holes, some tears, and we can see that the retina is attached in the temporal area. Uh, Retina is detached in the temporal area and attached in the nasal part. This laser marks could be clearly seen on the autofluorescence. Uh, the fundus photo of the right eye was the retina was attached, and we could see the laser marks over here. So he was diagnosed as left eye acute phakic rhegmatogenous retinal detachment with macula off. So early surgery was contemplated. Decision was to be made whether to do scleral buckle or VR procedure. He underwent left eye vitrectomy plus belt buckle plus endolaser silicone oil insertion under local anesthesia. Since the breaks were posterior, posterior laser marks were opening up, and there was opening up of lattices. It was decided to do vitrectomy. PVD was not present during intra-op, and PVD was induced with the help of IVT. IVT assisted PVD was induced, and it was extended anteriorly with extreme difficulty with suction in a bullous RD. So it had multiple iatrogenic breaks. The surgery was completed and silicone oil was put. This is post-op day 1. We could see there is slight haze because of the silicone oil. We can see the silicone oil sheen. We can see the laser marks, and a retina is attached and is in place. So while introspecting this case, what went wrong? Was the laser barrage burns heavy? What were the number of burns given and the number of sittings done, and the time interval between two sittings? So the barrage laser was done in two consecutive sittings on two consecutive days. Uh, the number of burns given were around 1300 in each eye, and the power used was around 180 to 190 milliwatt. On the second sitting, the laser burns was around 1100, and the power used was 170 milliwatt. At this point, we cannot comment that if the power was too much or too less because the patient also had posterior subcapsular cataract and early lenticular changes. So, was this rhegmatogenous RD due to PVD induction? But during intraop, we saw that the PVD was not induced. Were there any anomalous vitreoretinal adhesions on the fundus photo? We cannot comment. And was the barrage laser necessary in this case? So yes, the barrage laser was necessary because he had history of retinal detachment and spontaneously attaching retina in the other eye. We will discuss about it later. Moving on to case 2, a 50-year-old gentleman, known case of hypertension and diabetes. This case actually has a very big history, so I'm just briefing it down to the main event. He has in right eye status post vitrectomy, status post silicone oil removal. Left eye is lasered PDR with recurrent vitreous hemorrhage, status post ARC and status post anti-VEGF. Vision in the right eye is 3/60 and the left eye best corrected visual acuity is 6/9. Near vision in the right eye is more than N36 and left eye N6. Again, the anterior segment examination is normal. There is no evidence of any NVI. He had early lenticular changes in both the eyes and IOP is 12 mm mercury in both the eyes. On the fundus, we can see that the right eye, it is post-vitrectomized eye. It has some sclerosed vessel, unhealthy macula, and pale disc. So visual potential in the right eye was very less, and hence his vision was 3/60. In the left eye, he has lasered PDR with recurrent vitreous hemorrhage. So since this patient was on a follow-up from a long time and this vitreous hemorrhage was resolving, we found it as an opportunity to do fill-in laser. So his fill-in PRP was done in 2 sittings, again on 2 consecutive days. 1 week post laser, he presented to emergency with diminution of vision in the left eye. This time his visual acuity was 2/60 in the left eye, which was previously 6/9. He was treated this on fundus examination in the left eye. Again, there was a resolving vitreous hemorrhage. There was no evidence of any regma or traction, but there was macular thickening. He was treated with topical steroids, eye drop loteprednol for 6 days, 6 times per day for 1 week. He was reassured and was told to be on a close follow-up. This was his OCT on presentation. We can see a relatively compact inner retinal layers and a neurosensory detachment. So this shows that he had exudative retinal detachment. So after 10 days, when he came for follow-up, his vision improved. His vision in the left eye was 6/36. Retina was attached, vitreous hemorrhage was still resolving, and he was advised to be on follow-up. So this time you can see that his neurosensory detachment has resolved. Though the sections of both the eyes is not the same, they are not the same slab, but the retina was attached. You can also see some cystic space and hyperreflective dots, probably some hard exudates. So going on to just pondering upon his laser PRP settings, it was done in on 2 consecutive days. Burns on the first day was 681 and power use was 280 milliwatt. And in the second sitting, the power use was 220 milliwatt and 250 burns were given. This patient also, remember, this patient had early lenticular changes. And also maybe because of the vitreous hemorrhage, there is possibility, resolving vitreous hemorrhage, there is possibility that more burns, more power might be required. So again, introspecting this case, was the laser burns too heavy? And this was a neurosensory detachment, status post fill-in PRP. And again, another thing was his glycemic control and BP was not controlled, was poorly controlled. So his metabolic parameters were also deranged.
Go to the OCT. Okay. So if there is a massive exudate detachment, what else can be seen? Shifting fluid can be seen.
Configuration, you cannot give importance here because patient already had a laser done. So whole config, it will not typically go for the, you see link of a skip-ons rule depending on a whole position and you will have a RD configuration. It will not happen here because already lot of laser was done.
You examine meticulously the indirect or with the slit lamp. You can, in case if you have to rule out with the reg RD, you can pick up the edge of the vitreous traction, which is the acutely happened. So you can pick up those areas where the blood clots and the blood particles will give you some clue that there might be a hidden break there. Especially after your indirect, you put on to the 90D and then start seeing those areas. You may sometimes pick up the break
And
even beneath the blood also.
okay. Another thing is vision gone down immediately next 3-4 days, right? You said, if I remember correctly. So if you have to have a break related to the laser, not exactly either break can be due to heavy laser, that can happen immediately, but break secondary to contracting laser burn, it will not happen on 3rd or 4th day. So pigmentation and contraction may be around 2 to 3 windows. So patient may come back during that time and then obviously you are suspecting rheumatous component, but immediately if it's coming, more likely you are dealing with inflammation. Of course, 100% you cannot be sure and because of heme is there. So give a chance what you have done rightly, give a chance, a course of steroid. If it settle down, fine. If doesn't, then obviously you are going to go in and then anticipate, expecting that this rheumatous is not settling down. Okay. Now, another important thing comes here is when you have this recurrent heme, you said 2 sittings of laser, but looking at a picture previous, what your drawing is done, where was the space to do laser?
Sir,
Was there active prolif there?
yes, sir. We can see the elevated NV is present, and he had history of
No,
recurrent-
elevated will always be there because you have an incomplete PVD and you have a disc attachment. Obviously, it will be elevated. And disc polyps are always elevated, right?
Yes, sir.
Yeah.
He had history of recurrent vitreous hemorrhage despite doing laser, despite doing ARC, despite doing anti-VEGF. Secondly, there we can see in the periphery there are some, there was still scope for lasers.
No. Now again, there is always scope for laser. If you want to do, when you do PRP, is supposed to be intermittent. You have a spaces, so there is always scope for laser.
Yes, sir.
And the fact you said he had a recurrent bleed, what you need to look at it, whether you are dealing with an active proliferation process, dilated tortuous vessel, angry looking or red looking new vessels, or you have more fibrous component, that is, and then that actively bleeding. Or second thing is pre-existing blood vessel and you have, because of incomplete PVD, posterior highlight causing a traction on those existing blood vessels or avulse vessel or pooled vessel. So if it is now 2 things, either bleeding, recurrent bleeding, either can be because of recurrent traction or existing traction that intermittently cause bleeding, or it is because of active proliferation. Which of the 2 is more important in given case? Now, if you have active disease, obviously, and you have a space, you need a laser. But if you think tractional component is more prominent and that is causing this bleeding, so doing laser, you are worsening the traction further. And that situation, because it's a mechanical component, you need to go in and relieve the traction. So that situation, you need a vitrectomy, early vitrectomy probably, to differentiate between. So before I blindly, just because having a recurrent hemorrhage and just going blindly, go ahead with a recurrent, repeat it like if you fill in, because there is a space. You said scope is there. So first try to differentiate between 2 before saying yes, go and fill in PRP.
So this patient later underwent vitrectomy, and now he's doing fine. There is no.
There may be possible. I'm not saying that you are wrong, but how to differentiate? Yes, there may be space. Things work out well.
A good PRP covers what percentage of the retina? You're doing the full retina, no? So how is it covering only 30%? So that others understand. Your answer is right. A good PRP can cover only about 30 to 40% of the retina. But why? Spacing of the... So when you're doing one bit width apart, one burn width apart means you're already leaving 50%. And then you're also leaving the macula. And there is some part of the periphery which you will not. So you are actually treating only that part. So when you do a fill-in laser, You still have the other 50% of the retina, which is the one burn with space in between for such patients. But if you go back to the laser setting again, my concern is with the your exposure time or the duration is way too high at 200.
Probably with the blood there, maybe they would have used a little higher one.
Yeah.
Second setting only 250 burns.
Yeah.
That's not much space, and considering, yeah, Dr. Girish, what he's saying is duration probably because 200 plus 600, 800, 900 burn will not cause a sensory detachment.
Go ahead.
So coming to discussion, we mainly use photocoagulation techniques in doing PRPs, pan-retinal photocoagulation, Villen PRP, sectoral laser, focal laser, grid and modified laser, modified grid laser, focal lasers for CSR leaks, and barrage laser. So how should the laser burn be? There is a grading which says it can be graded into grade 1, 2, 3, 4 or light, mild, moderate or heavy. Light burn with barely visible retinal blanching, uh, light burn with barely visible retinal blanching, mild with faint white retinal burn, moderate with opaque dirty white retinal burn, and heavy with dense white retinal burn. So our target should be to achieve mild to moderate burns. In this diagram, we can see that there are all mild, moderate, and heavy, all three kinds of burns.
These are like all the burns are in the same sitting or two or second sitting, third sitting?
Sir, actually, this is an internet photo. Why I took was I could see all the three burns, though.
I think peripheral, those looking
yes.
at the older burns, not in a fresh. That's why intensity you cannot see. And other center burns, sometimes what you're seeing is central part is again intense, and surrounding that is a lighter one. Probably they were little bit heavy, but what happened? They are evolving now. Doesn't look like a fresh laser now. They are like over a period of 4 or 5 days or 1 week. Either that is now inflammation is stabilizing, or sometimes can have a second or third day when your initial heavy burn, particularly diode when you use. The initially on table, you give us a burn. Next day you see another ring around that because choroidal burn, which are deep choroidal burn, which is coming back and showing on a retina. And that's why when you do a diode, we specifically tell shallow light burns, because what happened, initial burn will be somewhere on choroid, looks very light on the retina. Next time they look very, very intense and around that. So central part is looking intense, surrounding that ring hollow, probably they are not fresh burn.
Also the spacing, it's very close actually. Normally we give burns with one burn width apart, and over time the laser burn expands. It looks like that only.
We should avoid, as ma'am said, we should avoid high intensity and confident burns. Do not treat over major retinal vessels, chorioretinal scars, area of fibrovascular polyps, areas of 3 and 9 o'clock where areas of long ciliary nerves are there, papillomacular bundle, NVD or elevated NVEs, areas of TRDs. What are the expected side effects? These are the expected side effects that can happen after a photocoagulation laser. We'll go through it one by one. So pain, as you know, but it can be reduced by shortening the laser pulse duration. Avoid long ciliary nerve positions at 3 o'clock and 9 o'clock. It can be done in staggered session as long as 2 weeks. Keeping the surface moist. In rare cases, one may need to give posterior subtenon block or peribulbar block. Even GA can be given in certain conditions, or Pascal laser can be used. There can be worsening of macular edema. The macular edema can be worsened. TDRS 9 says that there is increased risk of worsening macular edema with PRP done in pre-existing macular edema. DRCR.net says that splitting the treatment into multiple sessions may not help. So first, we need to treat the macular edema before doing PRP. It can be treated by either anti-VEGF or focal laser. As you know, we are burning the peripheral retina, so visual field is definitely going to decrease. Visual field sensitivity depression starts at around 2 weeks post PRP and it becomes stable at 4 months. There is loss of quality of color vision, especially the darker hues. Diabetic retinopathy cases, in these cases, there is already decrease in color quality, which is worsened after PRP. There is a reduction in contrast sensitivity, decrease in night vision. So there is elevated dark adaptation threshold. So in a darker room, there is difficulty in adjusting. Person finds it difficult to get adjusted in the dark room. Choroidal complications like choroidal effusions or choroidal detachment can happen. In this, there is rotation, anterior rotation of the ciliary body, which shallows the anterior chamber, which can lead to rise in intraocular pressure. Uh, but this is transient, and also since the iris, lens, diaphragm, everything is moving ahead, there can be transient myopia. This is self-limiting and good, but spreading the treatment over weeks can we prevent this? Is it's debatable. Certain misdirected intense burn can actually cause CNVM. Bleeding from the choriocapillaries can occur. Break in the Brooks membrane predisposed to CNVM. This ruptured Brooks membrane lead to synthesis of growth factors from the RP causing CNVM. And lasering the already underlying ischemia, already underlying ischemic retina can also cause to CNVM. Exudative retinal detachment, intense treatment lead to choroidal inflammation, breakdown of the RPE barrier with resultant fluid exudation. This usually happens in the single session group of patients. It resolves within 2 weeks. It is self-limiting, and there is no long-term vision loss. The vision can be regained back. Systemic disease plays a role, as in our case, even the systemic parameters were deranged. So that could be one of the cause for exudative retinal detachment. In certain rare cases, short course of oral corticosteroids or NSAIDs may be required in non-resolving cases. Some other complications like vasovagal attack, vitritis, PVD-induced vitreous hemorrhage, and epiretinal membranes. So post-laser advice is very important. Topical steroids like loteprednol should be started 4 to 6 times a day, at least for 5 days. And oral NSAIDs can be used, lubricating eye drops. Patient should be advised to avoid straining, avoid lifting heavy weights, avoid doing Valsalva maneuver for 1 month. He should always be advised the signs and symptoms of retinal detachment. Coming to barrage laser, whom to treat? So according to AO guidelines, any acute symptomatic patients, may it be operculated hole, horseshoe tear, or dialysis, they need to be treated. Asymptomatic patients with atrophic hole or operculated tear can be observed, but asymptomatic horseshoe tear, even with no SRF, should be treated promptly. Asymptomatic dialysis requires treatment. And eyes with atrophic hole or asymptomatic retinal tear where the fellow eye had RD, we should consider treatment. So when to treat? If there is history of retinal detachment in the fellow eye, family history of retinal detachment, patient cannot come for follow-up, physically active patient like career in sports personnel, etc. needs to be treated. Patient undergoing refractive surgery or cataract surgery, and high myopia. Lattices, which one to treat? So lattices with tractional holes or breaks within it. Symptomatic lattice like flashes and floaters. Again, this symptomatic lattice with flashes and floaters, like 1 or 2 flashes in a month or two, we may not treat them. But if he's having severe symptoms of flashes and floaters, then we need to treat. Contralateral RD, as Dr. Ramya asked, like could we have observed? So since that patient already had spontaneously attached retina, so he had history of RD, so we shouldn't observe and we should have treat, and he rightly did so. Patient undergoing refractive procedures or cataract surgeries, lattices with subclinical RD surrounding subretinal fluid of less than 1 disc diameter in size. One-eyed patients, family history of retinal detachment, or typical lattice degeneration, radial or paravascular lattices. So which one to observe? So asymptomatic lattices with or without holes can be observed, but they need to be followed up regularly. Uh, we need to laser if the patient is aphakic, pseudophakic, the risk of SRF beneath, and other risk factors, as already mentioned before, are present. So, what are the preferred practice pattern we follow at Shankar Netralaya for barrage laser? We have classified into 4 groups: absolute indication, relative contraindication, and special situations. So absolute indications, like patient with symptomatic retinal break, retinal tear in aphakic and pseudophakic eyes, retinal break in fellow eye when one eye has retinal detachment, retinal break in eyes with high myopia, lattice degeneration with atrophic holes and subclinical retinal detachment less than 4 disc diameter, traumatic retinal dialysis. Relative indication is lattice degeneration with atrophic holes in above circumstances, lattice degeneration with eyes undergoing LASIK procedures, eyes with coloboma of choroid. In this, if the disc is not involved and the intercalary membrane is detached, then we can laser it. Glaucoma patient with pilocarpine treatment, we can laser them since we cannot dilate. They are difficult to be dilated and examined. Relative contraindication is multiple rows of lattices which are present 360 degree and they are posteriorly present. So in this, the la- risk of doing barrage laser to the lattice does not the risk benefit ratio does not help. The coloboma with optic disc involved. In coloboma with optic disc involved, if we can definitely not laser in above the optic disc since the retinal nerve fibers layer will be affected. So this coloboma with optic disc involved are better left alone, as if we are not lasering that area, we are not there are still chances of retinal detachment. Special situations like in presence of significant cataract. So ideally, before any eye surgery, intraocular eye surgery, the barrage needs to be done. But if the cataract haze is too much, we can do barrage 3 to 4 weeks after the surgery. In case of vitreous hemorrhage due to PVD, we should tell the patient to be on bed rest and observe the patient after 2 weeks. If the vitreous hemorrhage resolves, and then if we see any breaks or something, we can laser it. Uh, if there are many lattices in one patient, maybe 360 degree lattice with no absolute indication of barrage, we may not barrage all the lattices. We may just barrage 1 or 2 lattice which are showing breaks or some indication is there or some indications are there. Laser settings should be spread out. Laser should be spread out away from the edge of the lattice. Separate each lattice should be separately covered. Anterior edge should be well covered. If we are not able to cover the anterior edge, we should at least cover up to the aura. The burn should be light, and we can space the treatment in more than one sessions. We should always instruct the patient of not exerting, straining, or doing Valsalva manual. In this, we can see that the lattices are all lattices are separately barraged. Though we can see that on the temporal side, there are still some lattices which are yet to be lasered. This is a horseshoe tear which is lasered in 2 to 3 rows. On the right, the first image, we can see that there is a small horseshoe tear with some SRF underneath, and this is well lasered. In this photo, we can see that the lattice, the horseshoe tear is not adequately lasered, and which has the anterior margin of the horseshoe tear is not lasered, which has led to retinal detachment. So in this case, if ideally the anterior margin should have been lasered, or at least this laser mark should have been reaching the aura. Thank you.